Good morning everyone. Today we will deal with the other herpes viruses. The other herpes viruses that I am going to deal with today are Varicella-zoster virus, Cytomegalovirus, EBV, Epstein-Barr virus, and HHV 6, 7 and 8. So coming to this Varicella-zoster virus, also called as HHV 3. For a long time, this was confused with the smallpox virus. Only in the early 1700s, when William Heberden was the first physician to differentiate it from smallpox, and then it was known as altogether a different virus. This is a virus which causes two important clinical conditions in humans: chickenpox in children and zoster in adults. That's why it is called as Varicella-zoster virus. Coming to chickenpox. Chickenpox is the most common childhood infection. Please remember, most common childhood infection. Some of you, at least few of you, would have suffered from chickenpox infection during your childhood. So what is this chickenpox? Chickenpox, the source of infection is always a child, some other child who has suffered from chickenpox, or an adult who has suffered from zoster. So the mode of infection is respiratory or very rarely through conjunctiva also. Infectivity is maximum during the initial periods of an incubation period of 7 to 23 days. We say infectivity is maximum 2 days before and 5 days after the rash has arisen. Secondary attack rate is around 70 to 90%, means it is highly contagious. Secondary attack rate means whenever there are children who are prone to getting chickenpox, when they come into contact with a child who has chickenpox, around 70% of them, minimum 70% of them will catch the disease. That's what we mean by secondary attack rate, which shows that it is highly contagious. Now coming to the pathogenicity of this VZV, Varicella-zoster virus. So as I told you, the route of transmission is respiratory. So once it enters from the conjunctiva or upper respiratory tract, like any other viral infection, the virus multiplies first in the lymph nodes. Then it spills over into the bloodstream, causing primary viremia. As any other virus, it later on goes to the reticuloendothelial system, here liver and spleen, where it multiplies for a while, then spills over into the general circulation, causing secondary viremia, and then through the general circulation goes and settles into its target organs. Here the target organ is the skin, very rarely lungs, central nervous system. Okay, so the target organ is skin, and so the lesions are seen in the skin. What type of lesions are seen in this infection? The rash. Every rash has to go through a sequence of macule, papule, vesicle, pustule, and scab. But in Varicella-zoster infection or in chickenpox, we see that these rashes arise, or these lesions arise in crops, that is multiple of them at a time, and we will not be able to appreciate the exact sequence of a rash, that is macule, papule. They may not go into that sequence. In a crop of these lesions, we may find few of the rashes, few of the lesions which are as macules, few of them which are as pustules, few of them which have already formed the scab, like that. So the stages of this macule to papule to vesicle to pustule is very, very rapid, and it starts crusting, that is scab formation, within 48 hours. Itching may sometimes be there, but invariably there will be fever, sore throat, weakness, that is myalgia or generalized body aches, and lymph node enlargement in the children. If it attacks in adults, that is first time that means the adult has not undergone or has not been exposed to chickenpox or has not suffered chickenpox in the childhood, then in adults he may suffer. The chickenpox in adults is sometimes quite aggressive, and it may lead to systemic complications like pneumonia in elderly and pregnant women. But once you suffer from chickenpox, you get a lifelong immunity. Now, what are the complications of chickenpox? It's extremely important. Chickenpox can cause severe or serious complications in adults, which involve varicella pneumonia, myocarditis, nephritis, acute cerebral ataxia, meningitis, encephalitis and Reye syndrome on taking salicylic acid. You all must be already aware, Reye syndrome is when you take salicylic acid, you see a HJ kind of reaction. Now, what is more important is chickenpox causes severe complications in pregnancy, and it depends on when the pregnant woman was infected with chickenpox virus. Based on that, it may be either fetal varicella syndrome or congenital or neonatal varicella syndrome. So, if the woman gets chickenpox in the first half of pregnancy, the child may get fetal varicella syndrome, which will be manifested as chorioretinitis, limb hypoplasia, and CNS defects. That means child is born with congenital defects if the infection to the mother is in the first half of the pregnancy. For all you know, sometimes these mothers who get chickenpox in the first half of pregnancy, the children may be asymptomatic also, though the percentage is quite less. If the mother gets exposed during the second half of the pregnancy, then the rash appears just before delivery, then the child may have perinatal varicella infection, which will generally be like a pneumonia or encephalitis in the baby. That's why when chickenpox is developed or diagnosed in mother, VZV, that is varicella antiserum, and the treatment or the drugs for antiviral drugs for the virus have to be given to the mother. Now, this is a table which shows what will be the outcome when based on which period of gestation the mother gets infected. If it is within first 7 to 28 weeks, then definitely they are going to be fetal varicella syndrome, which is, as I told you, manifested by chorioretinitis, limb aplasia or hypoplasia. Okay, then neonatal herpes after 28 weeks, just before delivery or 2 weeks before delivery, neonatal chickenpox, which will be similar to childhood chickenpox, may be seen. Now, coming to zoster. Now, zoster is an infection or a clinical condition in adults who have suffered chickenpox in the childhood. All of you are already aware that these herpes viruses are known for their latency. Means they remain inactive after they cause the disease, after they manifest the disease, say in childhood. For example, the VZV manifests in childhood. Then the virus remains latent in the neural ganglia. Here for VZV it is the trigeminal ganglia where it remains inactivated. Then in adult life, in multiple situations like immunocompromised conditions, it may get reactivated when it leads to a condition called as zoster. Now, this zoster is different from chickenpox. The manifestations will not be like primary chickenpox. The zoster is also called as shingles. So what you need to remember is zoster is not the primary infection of VZV. It is reactivation of the primary VZV infection. Why reactivation? Immunocompromised situations. And reactivation from where? Because it is lying inactive in the trigeminal ganglia. Now, what are the presentation in zoster? Generally, since it is lying inactivated in the trigeminal ganglia, so once it starts reactivate, it gets reactivated and it starts multiplying, it will spread along the trigeminal nerve, and wherever the nerve supply is there you can see the rash. So the major difference between adult chickenpox and a zoster would be, see, chickenpox rash, as I told you, is centripetal. Means first it is seen in the trunk and it is generalized. Whereas the rash seen in zoster is always dermatomal. Means wherever whichever dermatome the nerve is supplying, only there you will see. It is invariably unilateral. Okay, and since the trigeminal nerve is involved, is the commonest involvement, the ophthalmic branch of trigeminal nerve can be most commonly involved, and this rash is similar to the rash of chickenpox. That is, you can see it appears in crops, you can see all the stages in the same area, but what you have to observe is it is dermatomal. It is not generalized, it is not centripetal. You will not see it on trunk and all. You will see it only along the nerve innervation. Whichever dermatome the nerve has innervated, only there you will see this rashes. Now, as I told you, in 2 weeks it definitely heals, but complications are quite severe. And most important complication is, or the most common complication is the post-herpetic neuralgia. Post-herpetic neuralgia means the pain along that nerve endings exists for around 3 to 6 months. It is quite painful. Patients mainly come with the pain. Very rarely meningoencephalitis, if it's and lower motor neuron paralysis can be seen. Again, in adolescents and young adults, we can see Ramsay-Hunt syndrome. Ramsay-Hunt syndrome is when the facial nerve is involved. It is a tetrad of facial nerve involvement. So you can see a Bell's palsy. I hope you all know what is Bell's palsy. It is one-sided facial nerve involvement. So one side of the mouth, the angle of the mouth is paralyzed. So facial nerve involvement or Bell's palsy, along with the lesions on the tympanic membrane, the oral cavity and the pharynx. This tetrad is called as Ramsay-Hunt syndrome. And sometimes herpes zoster ophthalmicus, as I told you, ophthalmic branch of the trigeminal nerve is commonly involved. So the upper eyelid, you can see lot of lesions and paralysis of the muscles of upper eyelid, which we call as herpes zoster ophthalmicus. These are the common complications of zoster in adults. Now, coming to the laboratory diagnosis. Before that, I want to tell you a word about the clinical diagnosis. The moment you see rash, the typical kind of rash, you will diagnose it as either chickenpox or zoster. What you have to stress upon is, did the patient suffer from chickenpox in childhood? If the patient has suffered, then it is most likely zoster. You have to find out what was the stress or what was the immunocompromised condition which led to activation of the zoster. Or it may be, if it is a child and it is the first infection, the child or the parent will tell you that the child has never suffered before with this chickenpox like rash, then you have to diagnose it as chickenpox. If it is an adult, it may be chickenpox or zoster. Whether it is chickenpox or zoster depends on the previous history, as well as seeing for or looking for dermatomal involvement of the rash or centripetal involvement of the rash. With this, you can clinically definitely diagnose. It is the easiest condition to diagnose. None of the doctors go wrong in diagnosis of either chickenpox or zoster. Now coming to the laboratory diagnosis. So as I told you, clinical diagnosis is extremely easy. Equally important is lab diagnosis. How are we going to do the lab diagnosis? Lab diagnosis is mainly demonstration of the inclusion bodies. All the herpes viruses, I hope you know, are DNA viruses. Hence, they multiply in the nucleus of the host cell. So there will be large intranuclear inclusion bodies which can be demonstrated. How are we going to demonstrate that? We take the scrapings from the base of the lesion, like a vesicle or pustule. Never take from the scab, because the virus there is already dead. So from vesicle or pustule, the base of that lesion, we take scraped skin flakes, or sometimes sometimes we may get even the fluid. A smear of that is made, stained with toluidine blue, left for 15 seconds and observed for appearance or for the presence of large intranuclear inclusion bodies, which we call as Zancke cells. Yeah. Virus isolation or virus culture is quite difficult, has to be attempted only in human amnion, HeLa or Varicella. Hence, it is not a modality for diagnosis. It is only for research purposes. Then we have very good serological techniques like ELISA and immunofluorescence and CIE using the zoster serum. Prophylaxis and treatment. Since I told you this is the most common childhood infection, we have a very good live attenuated vaccine for zoster. It is derived from or attenuation of Oka strain of Varicella in 1974. Even now the same vaccine is used. It is a live vaccine to be given in 2 doses, one at around 15 months of age, the other at around preschool age, means 4 to 6 years. It is an extremely good or effective vaccine, and specific therapy, that is post vaccination also, some may develop rash only in elderly or complicated conditions, immunocompromised conditions only they may develop rash due to the vaccine strain. That time the treatment would be acyclovir or famciclovir. Now, this Varicella-zoster immunoglobulin is available, has to be given within 72 hours of appearance of the first rash, and it is preferred in women or pregnant women who develop chickenpox within 5 days or just the week of delivery. For them it is given. Or children with leukemia are also given this Varicella-zoster immunoglobulin, because again chickenpox is the most common childhood infection. Okay. Now coming to the next virus, that is HHV5. Now chickenpox or VZV was HHV3. This is HHV5. HHV stands for human herpes virus 5. Cytomegalovirus. HHV5 is also called as cytomegalovirus. Cyto is cell, megalo is big, megalo, big, and virus. This is a virus which causes the host cells to become big. Cytomegalovirus. This is the largest herpes virus, and it exhibits host specificity and cell specificity. That means the CMV viruses of humans cannot affect animals, and the CMV viruses of animals cannot affect humans. Means there is host or species specificity and cell specificity as well. That means they can grow only in a particular type of cells. Even in growth, when we want to grow them in vitro, only human fibroblast cell line only has to be used, and it grows very slowly. Slow cytopathic effect, around 50 days it takes to form the cytopathic effects, and the cytopathic effects are enlarged infected cells, very predominant intranuclear inclusion bodies. Again, this is a herpes virus, a DNA virus, so it multiplies in the nucleus, so it forms intranuclear inclusion bodies which are very large, and just outside the nuclear membrane we can see some deposit. So together the intranuclear inclusion body and the perinuclear deposit together makes the nucleus look very, very big. Okay, and it causes important infection or important manifestation of CMV is childhood or the congenital CMV infection. In adults who are immunocompetent, it causes mononucleosis, and in immunocompromised it causes severe CMV infection. Mode of spread is saliva, and route of transmission is generally the respiratory tract, but blood transfusion, transfer with transmission through urine and semen also has been detected. As I told you, clinical features are, it can be congenital CMV infection, wherein it is intrauterine or perinatal infection, and CMV infection in immunocompetent adults, which is the mononucleosis like syndrome, and CMV infection of the immunocompromised. Now, CMV infection in newborn or the congenital CMV infection is a very, very, very common intrauterine infection, has led to a very high fetal death of 20%. It's called as cytomegalic inclusion disease. Congenital defects that are seen are hepatosplenomegaly, jaundice, microcephaly, cerebral calcification, chorioretinitis, MR, mental retardation, and death. Infants who are born with cytomegalic infection are born to mothers who develop the infection in early pregnancy, and many a times there is death of the baby. If it is reactivation, chronic subclinical infection may be seen in the child. Perinatal infection means if the mother develops infection in the later parts of pregnancy or just before the delivery, the child develops a perinatal infection which is almost asymptomatic, but the child is known to shed the virus for many years, as long as around 2 to 4 years the virus is being shed in urine. In immunocompetent individuals, immunocompetent adults, mononucleosis-like syndrome means a condition, infectious condition called as infectious mononucleosis, which I'll be discussing later in EBV virus. A similar mononucleosis-like syndrome can be seen in immunocompetent adults by CMV. Then in immunocompromised, it causes a severe disease of chorioretinitis, gastroenteritis, dementia, and in people who have undergone bone marrow transplant, we can see interstitial pneumonia, leukopenia, graft rejection. Graft atherosclerosis means in people who have undergone bypass surgery, the graft atherosclerosis, the grafted vessel becomes atherosclerosed. That is a very common, and graft rejection is very common if there is CMV infection. All these immunocompromised states, CMV infection becomes very, very severe. Lab diagnosis: culture is by human, only growing in human fibroblast cell line, and these cells after the growth, after say around 6 to 8 weeks, because it takes, as I told you, around 50 days to cause the cytopathic effects, they will be tagged with fluorescent antibodies and demonstrate the cytomegalic cells. Serology, we have a good ELISA, immunofluorescent antibody testing we have, where we can demonstrate the antibodies. Now, see, look at this. This is a typical of large or cytomegalic inclusion bodies. The two big things are the inclusions that you are seeing, which gives an owl's eye appearance, they are the inclusion bodies seen in cells which are infected by CMV. Owl's eye means large eyes. The large eyes appearance is due to the large intranuclear inclusion bodies, intranuclear and perinuclear deposit. So the inclusion bodies appear very, very large, and they will give a typical owl's eye appearance. Prevention and treatment. Treatment is with ganciclovir, valganciclovir. Acyclovir may not work in CMV, so it should not be used. Derivative of acyclovir called as ganciclovir or valganciclovir or foscarnet can be used in people who are allergic to ganciclovir. Otherwise, ganciclovir is the drug of choice. Then CMV immunoglobulin is available to be given in women who have contracted CMV infection, pregnant women who have contracted CMV infection, and in bone marrow transplant recipients. Now coming to the most important or one of the important herpes viruses, HHV4, or also called as Epstein-Barr virus, EBV. EBV belongs to the gamma herpes viridae subgroup of herpes viruses, and it infects B lymphocytes. In children, it may be asymptomatic. In infants and early childhood. In adolescents, it causes a disease called as infectious mononucleosis, and in EBV is also known to cause large number of lymphomas, tumors. The infectious mononucleosis is also called as Kissing's disease because the source of infection is always saliva. So the clinical conditions, as I told you, infectious mononucleosis and a large number of tumors, which are the tumors caused by EBV. This is also a very, very common PG entrance question. All the following are tumors caused by EBV except. So which are those tumors? You should know. They are Burkitt's lymphoma, lymphomas in immunodeficient persons, nasopharyngeal carcinoma, and oral hairy leukoplakia. These are the tumor conditions caused by Epstein-Barr virus, or viral etiology is known in these cancers. Now, pathogenicity. Pathogenicity, once it enters through the pharyngeal epithelial cells through CD21 receptors, it makes these it attacks the B lymphocytes, and it brings about two changes in the B lymphocytes. What are they? First, the B lymphocytes become immortalized and they go on multiplying polyclonally. So large amount of antibodies which are non-specific are produced, and sometimes when a few of these infected lymphocytes, when they rupture, they will cause infection of the other lymphocytes. So it becomes a vicious cycle. There is blast transformation of the T lymphocytes leading to continuous uncontrolled growth of the lymphocytes and leads to small lymphomas. And these lymphomas in certain places like the South American countries, due to their genetic and environmental conditions, nasopharyngeal carcinoma and Epstein-Barr virus, the Burkitt's lymphoma are seen in these countries, certain African nations and the South American countries. Now coming to infectious mononucleosis. This is a self-limiting condition, 4 to 8 weeks. It will remit or it will subside on its own, but it is characterized by the patient is generally a young adult, comes with fever, sore throat, lymphadenopathy. Please see for do a peripheral smear, means ask for a CBC test, do a peripheral smear and see for abnormal lymphocytes present in peripheral blood. That will give you a clue that it could be an infection by Epstein-Barr virus. Lab diagnosis. So peripheral smear, as I told you, shows abnormal mononuclear cells. And serology, we have very good serological tests available for this. This is the Paul-Bunnell test, which is also a heterophile agglutination test. Heterophile means the antibodies produced against the virus agglutinate something else. Okay, so which what do they agglutinate, which antigen do they bind to? Here the heterophile antibodies produced against the virus of EBV, they will agglutinate the sheep erythrocytes. Hence this test, Paul-Bunnell test, is also called as heterophile agglutination test. I want to remind you here at this point that other heterophile agglutination tests are Weil-Felix test, if you remember, for rickettsial infection, and a cold agglutination test done for mycoplasma. These are other heterophile agglutination tests. Because why I am telling you this here? Because heterophile agglutination test is a very, very common 5 marks question in microbiology. That time we do not expect you to write only Paul-Bunnell. We expect you to write Paul-Bunnell, Weil-Felix and cold agglutination test for mycoplasma at least. Alright, okay. Then we have other tests wherein we can demonstrate antibodies to EBV through ELISA, and we have demonstration of EBNA, that is the cells which exhibit Epstein-Barr nucleic acid on their surfaces. Now, the other herpes viruses, that is herpes HHV6, HHV7 and HHV8 are not very common. HHV6 is known to cause disease in infants called as Roseola infantum or 6th day disease. Means on 6th day of birth they develop, the baby or the infant develops rash around the cheeks. It is a quite self-limiting conditions and quite a mild disease. Now HHV7 and HHV8 are known to cause co-infection along with HIV, because HHV7 shares the same CD4 receptors on the T cells as the HIV, and HHV8 is known to cause Kaposi's sarcoma in HIV AIDS patients. That is, when a HIV patient goes in for AIDS, means when the CD4 count goes much below, when all the opportunistic infections are seen, that time Kaposi's sarcoma is a very, very common presentation, and Kaposi's sarcoma is produced by HHV8. So HHV8 is a common opportunistic infection in AIDS patients. So today I have covered HHV3, HHV4, HHV5, HHV6, 7 and 8. Important ones are HHV3, that is Varicella-zoster virus, HHV4, Epstein-Barr virus, HHV5, CMV, Cytomegalovirus. With that, we come to the end of this class. Thank you.